Our next question in the series: outline the possible reasons for prolonged paralysis involving intravenous dose of 1 milligram per kilo of suxamethonium. So, what's our structure? We're going to define what suxamethonium is. So, sux is depolarizing muscle relaxant nicotinic ACH receptor agonist at the neuromuscular junction. And then the root, I guess, right? So what does it do? It enters the plasma 90% fractured immediately, metabolized by pseudocholinesterases, and then 10%, the remaining 10% fraction enters the neuromuscular junction, binds to one of the alpha subunit groups on the postsynaptic NACHR. Agonism at the NACHR, ion influx, sodium in, calcium in, potassium and out. Depolarization, muscle fasciculations. However, sux bounds to the NACHR as no pseudocholinesterase is present in the NMJ to metabolize it. It also keeps the adjacent voltage gated sodium channels in an inactive state, causes flaccid paralysis. The offset diffusion of sux from this is more important obviously, so if you don't have time you don't have to write that. So we have to say the root, but more importantly is the offset. Diffusion of sux from the NMJ plasma following a concentration gradient. So the sux comes out by the concentration gradient. The dose is normally 1 milligram per kilo, 45-second onset. ED95 is 0.3 milligram per kilo. The duration is 10-minute offset. Return to about 95% baseline twitch 1 height. Causes of prolonged block is the inherited ones, which are the genetics. So the alleles you talk about FASU. On chromosome 3 you have the atypical, the silent, the fluorescent resistant and the normal. Prevalence, 96% are homozygous for the normal gene, 4% are heterozygous, which is 60, and very small amount is homozygous for the abnormal alleles, right? So bupivacaine number. Bupivacaine is an amide local anesthetic that inhibits normal pseudocholinesterase Y and is less effective at inhibiting the abnormal ones. And the reason why is because it's actually amide local anesthetics are also metabolized by pseudocholinesterase. The test measures the percent of inhibition. Greater than normal, 80 is inhibition. Then you have the acquired stuff. So you have a massive list here. And acquired, so you got pregnancy, which decreases, but it increases VD, so overall negligible. You got burns, elderly, you got myasthenia gravis, which increases the resistance, significant to sux, but more of a phase 2 block. BCHE deficiency due to pseudoplasmacytosis. Remember left shift to rock, therefore need less rock. This is just a memory thing. Remember myasthenia gravis, which is the MG car, it turns left and it hits a rock. So that's how you remember it's the left shift. Renal failure, increased plasma proteins, less nephrotoxic, loss of nephrotoxic syndrome, right? Cardiac failure, elderly, neonates. The drugs, competitive inhibitors, so anticholinesterase, so neostigmine inhibits ACHE and pseudocholinesterase. Mivacurium and ester, local anesthetic. Why? Because they decrease pseudocholinesterase because they actually metabolize. Non-competitive organophosphates. Others are like contraceptive, which inhibit liver synthesis of pseudocholinesterase, and ketamine inhibitor. Effect, prolonged block, and what do you do? Manage supportive care. You can actually give FFP. There's no antidote, genetic testing, sedation, and ventilation. All right.